report so that we can put this on our site. And welcome, and if you'll introduce Michelle, please.
Hi, Mandy. Thank you very much. I thought I would just pop the video on quickly so we can introduce ourselves, and then I'll switch it off. I'm Kathy, and to my right is Michelle Grobler. She's the Divisional Manager for the Fish and Paykel Respiratory Acute Care Division for Respiratory Care Africa. Michelle is going to introduce Optiflow nasal high flow therapy and take you through the mechanisms of action, and then I will have a look at some key studies and clinical applications for nasal high flow therapy targeted for ED, but also for overall hospital use, just to give you a comprehensive view of nasal high flow therapy. Again, Mandy, thank you very much for giving us the opportunity to present. Just to mention that we have been asked to minimize and not focus specifically on COVID-19. However, if at the end you'd like to see the information we have on COVID-19, we're more than happy to quickly show that to you. I'm going to hand over to Michelle.
Thank you, everyone, and thank you very much for the opportunity for us to discuss nasal high flow therapy, focusing on the emergency department, but as Kathy mentioned, throughout the hospital as well. So in previous years, prior to COVID, we were not able to, we didn't have nasal high flow, and we basically were, our options was conventional oxygen therapy or then intubation. And with conventional oxygen therapy, whether it be through a nasal prongs, through a face mask or a rebreather mask, we were able to oxygenate the patient, but we were lacking alveolar ventilation. And that is what comes with nasal high flow. Because I think prior to COVID, a lot of us knew what nasal high flow was, but post-COVID, the majority of people are aware of what nasal high flow is and the benefits that it has. So in summary, we can say that nasal high flow is the administration of a conditioned gas, not specifically oxygen, but a conditioned gas. In other words, it's warmed and it's humidified at flows that are higher, which will meet or exceed your patient's respiratory demand. And by doing that, we are then able to provide respiratory support to our patient, and then we are able to supply more than just oxygenation, but alveolar ventilation as well. And with nasal high flow, we have afforded the opportunity to give everything from 21% oxygen up to about 95, even sometimes 100% oxygen to the patient. And that is why, so if we had to look at a patient being admitted into the ED, or a patient who suddenly presents with respiratory distress in the ward level, and a person we called up to go and evaluate them, you find that the majority of the studies start on a 40 or 50 liter of flow and on a 40% oxygen, more or less. We will discuss this a little in more detail later. But the crux of this therapy is the pressure that is created by the flow. And that is the main therapeutic module of nasal high flow therapy, is the creation of the flow, which creates the washout and the pressures, and then allows us to oxygenate the patient as a supplement. So this is then going to lead me into the next slide, which is the mechanisms of actions of nasal high flow. And the basis of the mechanisms of actions is to optimize the spontaneous breathing of the patient. And I'm emphasizing spontaneous breathing because this is a therapy that is indicated for patients who are able to breathe on their own. So respiratory support is supplied to our patient through the different mechanisms, and we're going to then go through each one in more detail. But it provides us respiratory support through the reduction of the dead space, as well as by creating a dynamic positive airway pressure through the flow. Through the humidification, we also allow for airway hydration, which will allow for the maintenance of the mucociliary transport system. We have the opportunity to add supplemental oxygen. And then last but most definitely not least is patient comfort. And these different mechanisms of actions are very different to what we had prior to nasal high flow with conventional oxygen therapy, and thus our physiological outcomes are different. So let's look at them in a little bit more detail. So the first one we're going to look at is the creation of a dynamic positive airway pressure. So with the creation of a dynamic positive airway pressure, the nasal high flow actually creates a breath and a flow dependent pressure, which makes our inspiration a lot easier, and it encourages slow, deep breathing on expiration, and this increases our alveolar ventilation. And if we look at the graph on the screen, you can see with unassisted breathing, if we look at the airway pressures over time, you've got a slight negative pressure and a slight positive pressure. But with nasal high flow, on expiration, you've still got a residual volume, and then it increases and then at the start of expiration, by breathing through this pressure, you're able then to increase the airway pressure. And this is obviously where a lot of therapeutic value is found. So this is thus creating respiratory support through nasal high flow for us. I will illustrate this through a short video, which will also show you. It's based on a study that was done by Corley, showing the low flow oxygen therapy or conventional oxygen therapy versus nasal high flow. And you'll see that there's a significant increase in the lung aeration in nasal high flow versus our conventional oxygen therapy. And this is based because the increased lung volume as well as the tidal volume on the patients. So on the schematic or on this video, we can see that there's a lot improvement tidal volume and ventilation for our patient. And this is obviously created through the flow. The next mechanism of action will be the reduction of the dead space. So as we are all aware that with expiration, our upper airways are filled with gas, which is rich in carbon dioxide. And by flushing this out through the higher flows, we are able to clear these airways. Therefore, we reduce the amounts of carbon dioxide that is inhaled, which is then replaced with oxygen-rich gas. And therefore, we also once again improve our alveolar ventilation. Again, I'm going to illustrate this with a short video that will then show you visually what the differences are. So we can see on the left, we have unassisted breathing with high CO2 being our red and the lowest CO2 is going from the green to the blue. We can see on the left, unassisted breathing shows high CO2 levels in our upper airways, and with Optiflow nasal high flow at even 40 liters per minute, we see a significant reduction of CO2 in the gas in our upper airways. This obviously promotes alveolar ventilation because we are now inhaling oxygen-rich gas rather than carbon dioxide-rich gas. The next mechanism of action is the airway hydration. On the Airway, you can set 3 different settings of 31, 34, 37 degrees Celsius for the temperature. And ideally, we'd like to set it at 37 degrees Celsius because that is where you are obtaining optimal humidity. So humidity enables us to deliver these high flows a lot more comfortably to our patients. And this humidity emulates the natural balance and the heat of the humidity in a healthy lung. And it helps us to maintain physiological stability in these compromised airways. We also see that this humidity allows for maintenance of the mucociliary transport system. And we've received some feedback, especially from nursing staff, saying that the nasal high flow creates secretions, which in fact isn't. It is the mobilization of the secretions that are already there, allowing the patient through this humidification to clear the mucus that is actually stuck in the airways. So thus we're also improving the ventilation as well as the oxygenation in these patients by allowing for mobilization of these secretions and maintaining the mucociliary transport system. I'm now going to show you a video as well, which demonstrates the benefits of humidification on a patient. My sound is on, I'm just double checking. If the sound does not come through, Mandy, please stop me and then I'll speak you through it.
As the clip starts, the right trachea has been exposed to a constant airflow.
Can you hear the sound?
For 15
Perfect.
minutes.
Perfect.
Although you can see tiny beating cilia flickering in the background of both clips at this stage, debris in the mucus of the right clip are stationary. Mucus transport is essentially stopped. The dark spots moving quickly across the left clip now show debris being cleared by effective mucociliary transport. After only an hour at the lower humidity, the mucus layer at the right has completely dried out.
So from that video, we can see what the impact is of just 90% humidity over 1 hour and the drying out of secretions. Just a practical implication is we have sometimes seen that initially a patient will be resistant to 37 degrees Celsius, but we then suggest that you start them at 34 degrees Celsius, and then when they look away after 15 minutes, you then increase it to 37 degrees Celsius, and they're then usually able to tolerate it. That's just a practical implication of this, because we ideally really want to get the patient to 100% humidity. The next mechanism of action is that we are then able to provide supplemental oxygen to the patient. With the Airway, you do not necessarily have to connect an oxygen source. You are able to deliver 21% oxygen with a flow of up to 60 liters, which can also be beneficial to your COPD patients who thus require the respiratory support and the humidification, but there's no requirement for oxygen. But because we are then able to give up to 95 to 100% oxygen on these, we are also more confident in the amount of oxygen that we are delivering to the patient. The reason for this is, for example, if your respiratory demand for a patient is 40 liters per minute, and we're supplying them with supplemental oxygen of 10 liters per minute maximum, that balance of 30 milliliters per minute is then supplemented or diluted with the room air that is being entrained. But with nasal high flow, we can, by correlating the flow meter and measuring of the fraction of inspired oxygen, you can actually avoid this dilution of it and give an accurate FiO2, as we mentioned, up to 95% for the patient. So we can be a lot more confident in the fraction of inspired oxygen for our patients. And then last but not least is the comfort that the nasal high flow provides our patients. So previously with a rebreather mask or on a face mask, or even now that we're using an NIV mask, your patient comfort is sometimes compromised, or the patient finds it a lot more uncomfortable. Where with nasal high flow, we're using very soft nasal prongs that fit comfortably into the nose. And we all know if the patient is comfortable, his tolerance is a lot better and he's a lot more compliant to the therapy. And therefore, you also see the benefits of nasal high flow for these patients. So that in a nutshell is the mechanism of actions behind nasal high flow. Are there any questions at this stage? Okay, I'm then going to hand over to Kathy, who's the product manager. Please feel free to also ask us questions as we go along. I see Chris Greville, who's from New Zealand, who's our international sales manager, has also joined the call. So thank you very much, Chris. We appreciate it after your long day in meetings. And I'm going to hand over to Kathy now.
Thank you, Michelle. I'm going to go through the clinical applications of Optiflow nasal high flow therapy, of which there are at least 5 that we've recognized in different areas of the hospital. And I'll be looking at clinical evidence to support these applications as well. The first one we'll be looking at is avoiding escalation, which I think is key for management of patients coming into the ED with acute hypoxic respiratory failure. The first one we'll look at is Bell et al., which was published in 2015 in the Emergency Medicine Australasia Journal. The aim of this trial was to look at a comparison of nasal high flow with conventional oxygen therapy in 100 patients with acute undifferentiated shortness of breath in the ED. It was a randomized controlled trial in 2 Australian emergency departments, and nasal high flow therapy was commenced at a rate of 50 liters per minute with an initial FiO2 set at 30%. So not high, not up at 100%, which I think is notable. The primary outcome looked at the need to escalate ventilation therapy or a reduction in respiratory rate of 20% or more in 2 hours. 45% of patients in the study had COPD. When we look at the results, it was found that there was a significant reduction in escalation in ventilatory support using nasal high flow therapy, 4.2% compared to 19% in the conventional oxygen therapy group. A higher proportion of patients had more than 20% reduction in the respiratory rate using nasal high flow therapy. Also, more patients demonstrated a reduction in dyspnea. They used the modified Borg score with 75% in nasal high flow therapy versus 55.8 in conventional oxygen therapy. There was also improved patient comfort overall with nasal high flow, scoring a numerical scale of 4 out of 5 versus 3 out of 5 for conventional oxygen therapy. Papachakatis et al. In 2020 was published in the International Journal of Environmental Research and Public Health. High-flow oxygen through nasal cannula provides adequate oxygenation and can be an alternative to non-invasive ventilation for patients with hypoxemic respiratory failure. The aim of this present study was to assess the efficacy of high-flow nasal cannula versus non-invasive ventilation in hypercapnic respiratory failure. This was run in the emergency department. It included 40 patients, 20 receiving non-invasive ventilation and 20 receiving nasal high flow with the Airvo. All patients were of similar gender, age, BMI, Apache score, and other factors between the 2 groups. The initial starting flow rate for nasal high flow therapy in this patient group, and this trial was 35 liters per minute, then titrated upward to a 45 to 50 liter per minute as tolerated to target saturation greater than 90%. When we look at the results, the PaCO2 at discharge was significantly lower in the nasal high flow therapy group compared to non-invasive patients. We saw an average of 50.8 millimeters of mercury versus 59.6. The respiratory rate was significantly lower in the nasal high flow groups as well. 7.5% of the non-invasive patients actually changed to nasal high flow therapy, and this was largely due to intolerance of NIV. Overall, there was no difference in mortality or hospital duration. So ultimately, conclusively, the lower PaCO2 in the nasal high flow group indicated that nasal high flow was superior to NIV in the management of hypercapnic respiratory failure for this randomized controlled trial. One of the other applications that we can use nasal high flow therapy for is for the pre-oxygenation or peri-intubation of patients. Miguel Montanes et al. In 2015, published in the Critical Care Medicine, looked at the use of nasal high flow therapy to prevent desaturation during tracheal intubation of intensive care patients who had mild to moderate hypoxemia. This was a prospective before and after study in University Hospital ICU. They enrolled 101 ICU patients who required intubation. 50 were randomized to non-rebreather mask only, and the other 50 included nasal high flow therapy. So how they did this was they put the patients on pre-oxygenation with a non-rebreather mask. This was the control period. And thereafter, they changed the 51 patients to nasal high flow. The primary outcome was to look at the median lowest saturation during intubation. When we look at the results, we see the median lowest saturation was higher for patients on nasal high flow during intubation. Nasal high flow was set at 100% versus 94% in the normal rebreather mask group. Patients in the nasal high flow group experienced less episodes of severe hypoxemia, which was defined as a saturation of less than 80%. So 2% in the nasal high flow group versus 14% in the non-rebreather mask group. Patients in the nasal high flow group could be continuously oxygenated throughout the procedure, whereas the patients in the non-rebreather group had therapy removed for intubation. So overall, nasal high flow reduces hypoxemic episodes during the peri-intubation period compared to non-rebreathing bag reservoir mask. Avoiding intubation is one of the key ideals when we are managing patients in the ED with acute hypoxic respiratory failure. And I'm just going to chat to you about the Fratt et al. Study published in 2015 in the New England Journal of Medicine. The aim of this study was to look at the number of patients intubated at day 28 when comparing nasal high flow therapy to non-invasive ventilation and conventional oxygen therapy. This was a 23-center study, and it was held in 23 ICUs in France and Belgium. They included 310 patients in acute hypoxemic respiratory failure, non-hypercapnic, with a PF ratio of less than or equal to 300 millimeters of mercury. They were randomized to receive nasal high flow therapy starting at 50 liters per minute and targeting oxygen saturations of above 90%. Alternatively, they were randomized to non-invasive ventilation, and then they were randomized to non-rebreather mask above 10 liters per minute. As I mentioned, the primary outcome was to look at the number of patients intubated to day 28. This was not attained. However, when they looked at the sub-hoc group in this trial, which was 77% of the overall patients who had a PF ratio of less than 200 millimeters of mercury, they found a significant reduction in the intubation rate at day 28. There was also significantly reduced ICU and 90-day mortality. Further to this, there was an increase in ventilator-free days on nasal high flow therapy, and it also reduced intensity of respiratory discomfort and dyspnea. If we have a look at the reduction in the overall 90-day mortality in this trial, nasal high flow sat at 12% versus 23% in the standard oxygen group and 28% in the non-invasive group. When we looked at that sicker patient group, the 77% with PF ratios of less than 200 millimeters of mercury, number of patients intubated on nasal high flow was 35% versus 53 in the standard oxygen and 58 in the non-invasive ventilation. So it's definitely proven to reduce escalation and reduce intubation rates in this patient group. Rachberg et al. Did a systematic review and meta-analysis which was published in the Intensive Care Medicine Journal in 2019. It was basically a review to summarize the safety and efficacy of high-flow nasal cannula in patients with acute hypoxemic respiratory failure. They performed a comprehensive search of Medline, Embase, and Web of Science. They identified randomized control trials that compared high-flow nasal cannula to conventional oxygen therapy. They pooled the data and report summary estimates of effect using relative risk for dichotomous outcomes and mean difference or standardized mean difference for continuous outcomes with 95% confidence intervals. They assessed risk of bias of included studies using the Cochrane tool and certainty in pooled effect estimates using grade methods. 100% of the analyzed studies used F&P Optiflow nasal high flow systems. They looked at 446 total trials and based this on 9 of the randomized control trials. The total patients equal 2,093. Nasal high flow is associated with a lower risk of requiring intubation. Nasal high flow is associated with a decreased escalation of oxygen therapy, and there was no difference in mortality between nasal high flow and conventional oxygen therapy. So in patients with acute hypoxemic respiratory failure, high flow nasal cannula may decrease the need for tracheal intubation without impacting mortality. This slide just shows you the different trials that were included. 5 of the trials in gray were actually done in the ICU, and 4 of the trials in blue were based in the ED. It's important to note the starting flows, which started at around 35 up to 55 litres per minute, and the mean flows also were around 35 up to 55 litres per minute. Inclusion criteria was mainly acute respiratory failure, hypoxic respiratory failure. There were patients with cardiogenic pulmonary edema and acute dyspnea and hypoxemia. One of the other areas that we can use nasal high flow therapy is as a rest break with NIV or non-invasive ventilation. Now, I understand that this is probably not a big application for the ED. However, if you are stuck with patients in the ED for longer than anticipated on non-invasive ventilation, this will help you to understand the importance of considering rest therapy on nasal high flow therapy. So this particular trial was done with Spallettini et al. In 2018, published in the Journal of Critical Care. His aim was to assess the role of high-flow nasal therapy compared to standard oxygen as a complementary therapy to non-invasive ventilation. It was also a prospective multi-center randomized controlled trial. They included 54 patients needing non-invasive ventilation for more than 24 hours. Patients were acute chronic hypercapnic and acute hypoxemic patients. They received either conventional oxygen therapy or nasal high flow while having rest breaks from NIV. The primary outcome was to look at the total time on and off NIV. There was no significant difference in this time between the two patient groups. However, the mean comfort score out of 10 was higher with nasal high flow, 6.9 in the conventional oxygen versus 8.3 in the nasal high flow therapy. Conventional oxygen therapy rest breaks increased respiratory and dyspnea during the breaks, and these effects were not seen with nasal high flow therapy during the rest breaks. I think importantly to note as well, obviously conventional oxygen therapy is cold and dry and is far less comfortable compared to nasal high flow therapy, which is optimally humidified. Patients are also able to eat and drink and also speak while they're on the nasal high flow therapy. So it's a very well-tolerated therapy for non-invasive ventilation rest breaks. Rochwerk et al. In 2020 published in the Intensive Care Medicine magazine or journal, basically looked at a number of trials to see what the role for nasal high flow therapy as a respiratory support strategy in adults looked like. And it was actually published in the European Society of Intensive Care Medicine as clinical practice guidelines. High flow nasal cannula is a relatively recent respiratory support technique which delivers high flow, heated and humidified, controlled concentrations of oxygen via the nasal route. Recently, its use has increased for a variety of clinical indications. To guide clinical practice, they developed an evidence-based recommendation regarding use of high flow in various clinical settings. They formed a guideline panel composed of clinicians, methodologists, and experts in respiratory medicine. And using the grade, the panel developed recommendations for 4 actionable questions. The result of this was that acute hypoxemic respiratory failure and the use of nasal high flow is preferred to conventional oxygen therapy for these patients as a strong recommendation by the panel. For peri-intubation, there was no recommendation being made regarding the use of nasal high flow in the peri-intubation period. However, nasal high flow during intubation should be continued for patients who are already receiving nasal high flow therapy. A conditional recommendation is being given for post-extubation respiratory failure. Nasal high flow is preferred to conventional oxygen following extubation in patients with any high-risk feature who were intubated for more than 24 hours. Important to note, NIPPV is preferred to nasal high flow in patients who would normally be extubated to non-invasive positive pressure ventilation. And then for post-operative patients, a conditional recommendation for the use of nasal high flow over conventional oxygen therapy for your high-risk and obese patients undergoing cardiac or thoracic surgery to prevent respiratory failure in the immediate postoperative period. Prophylactic nasal high flow to prevent respiratory failure in other postoperative patients is not recommended. I'm now going to just jump to usage in pediatrics. Basically covered the 5 applications. We didn't do a lot we didn't put a lot of emphasis on post-extubation, that this is not usually something that occurs in the ED, but it is there especially for use in ICU. So when we have a look, so nasal high flow therapy is definitely not just for adults. It's been used extensively for a number of years in pediatrics. And I'm just going to run through the Franklin et al. Paris study, which was published in the New England Journal of Medicine in 2018. This was the largest nasal high flow trial to date and answers the question, should nasal high flow therapy be used beyond the pediatric ICU? They included 1,472 infants, less than 12 months old, who were admitted into the ED and the pediatric ward with bronchiolitis and hypoxia. 17 emergency departments and general pediatric wards across Australia and New Zealand participated. The mean age of infants was 6 months with a mean weight of 7 kilograms. Infants were randomized to receive either nasal high flow with the F&P Optiflow Junior at 2 liters per kilogram per minute, and patients were randomized to receive oxygen therapy with nasal cannula at a maximum flow of 2 liters per minute. The primary outcome was to look at treatment failure requiring therapy escalation or pediatric ICU admission. Secondary outcomes looked at hospital length of stay, duration of oxygen support, ICU admission, length of stay, and intubation. The results showed that nasal high flow therapy appears safe in a large data set when delivered to infants with bronchiolitis in the ED and general pediatric wards. There was no significant difference in terms of the secondary outcomes. The use of nasal high flow resulted in a significantly lower rate of treatment failure compared to standard oxygen therapy. If we look at the primary outcome over here, 77% of the oxygen therapy patients responded with a 23% therapy failure, compared to an 88% positive response in the nasal high flow therapy group with a 12% failure. I think it's important to note that during the trial, one realized that it would be unfair not to give the patients who failed conventional oxygen therapy a rescue opportunity on nasal high flow. And in fact, this is exactly what they did. And of the 23% that initially failed therapy, which was 65 patients, they then rescued them on nasal high flow therapy, and 102 were rescued on nasal high flow therapy, and then 39% failed, leading to an overall pediatric ICU admission in the conventional oxygen therapy group of 9%. The patients on nasal high flow therapy obviously couldn't be rescued on nasal high flow therapy, and the PICU admission was set at 12%. So there's definitely an opportunity, a valid opportunity to use nasal high flow therapy and prevent escalation and intubation in this pediatric group. And I think in the South African setting, not every hospital has a pediatric ICU, and there's a large cost involved in transferring these children to hospitals with facilities, pediatric ICU facilities. This becomes even more evident in the government setting, an overall cost of transferring these patients, as well as the cost on the community in terms of parents having to move to the hospitals where their children are being managed. So one of the questions that we get asked when we present nasal high flow therapy is how to use the nasal high flow therapy and whether we have any algorithms that we can advise on. I think ultimately the clinical decision remains with the clinician in terms of how they want to manage patients, but there are a number of usage algorithms that you can refer to, that you can utilize and also modify for your various departments. This particular one has been published in the Journal of Chronic Obstructive Pulmonary Disease by Sharkey and Pantotzopoulos in 2019. And this is the recommended algorithm for high-flow nasal cannula use in acute hypoxemic respiratory failure with either immunocompetent or immunocompromised patients. If we have a look here, important to note, if there's criteria for immediate or imminent intubation, please don't play around with nasal high-flow therapy. Intubate and ventilate the patient as required. However, if the patient does not require imminent intubation, it's recommended to start at flow rates optimizing 60 liters per minute if the patients can tolerate it at a temperature of 37 degrees Celsius, and with these patients recommended to start at 100% FiO2. However, it's important to monitor these patients and to, as quickly as possible, decrease the FiO2 to target saturations of above 90%. Don't leave your oxygen at 100%. Anyway, one can go through the actual protocol and follow it as you decide in terms of your departments. There's a second algorithm suggested for nasal high flow use in acute hypercapnic exacerbation of COPD. This is part 1. And then we also have a suggested algorithm for part 2 in terms of exacerbation of COPD. One of the other algorithms suggested is using the RUX Index to help with an intubation decision. So this is for patients that you start nasal high flow therapy on and need to assess in terms of whether the nasal high flow therapy is working or not. Because the index includes in a single value 3 relevant respiratory parameters, the overall philosophy of the index is that if its value is increasing, the patient's respiratory status is improving and you can continue with nasal high flow therapy. RUX calculations are made simple by using our app, which you can download on Android or iOS platforms. It's the F&P RUX calculator, which you can see over here. So what is the RUX index? The RUX index is defined in Rocker et al. 2019 as the ratio of oxygen saturation to inspired oxygen to respiratory rate. The study confirms the accuracy of the index for determining which patients treated with nasal high flow may not require intubation. How is it calculated? The equation for calculating the RUX index is your oxygen saturation divided by your FiO2, and this number is then divided by the respiratory rate. If you use the app, it takes you through the steps and is very easy to do, and it will then calculate the value for you. A RUX index of greater than or equal to 4.88 after nasal high flow initiation is associated with a lower risk of intubation in adults with acute hypoxic respiratory failure due to pneumonia. It's important to note the RUX index has been validated in the pneumonia patient group, to date not other patient groups. So if we have a look at the diagram over here, we can evaluate the RUX index and validate it at 2 hours, 6 hours, and 12 hours. So if we look at the 2-hour patient, you will have initiated nasal high flow therapy and then evaluate at the 2-hour mark. If your RUX index is less than 2.85, one needs to consider intubation. If the RUX index is between 2.85 and 4.87, increase support and reevaluate in 30 minutes. You then need to look at the change in your RUX index. If it is less than 0.5, consider intubation, and if it is greater than or equal to 0.5, you can continue monitoring. You can then reevaluate at 6 hours with the parameters as explained, and then once again at 12 hours. So one of the other algorithms that we have is obviously the COVID-19 treatment algorithm. I'm not going to go through this, but know that it is available and we can give you these references. I will make everything available to Mandy after the presentation. So now I'd just like to summarize what we've discussed so far. We've looked at the key mechanisms of nasal high flow therapy, those being respiratory support, where we increase flow and increase pressure for patients, airway hydration, patient comfort, and the ability to give supplemental oxygen to these patients when required. Remember that your flow of 60 liters is independent to the amount of oxygen that is being given to the patient. The physiological outcomes show that nasal high flow therapy improves ventilation and gaseous exchange. It reduces the respiratory rate and carbon dioxide. It increases tidal volume and end expiratory lung volume, and improving mucus clearance with the optimal humidity, and then improving oxygenation with the ability to supplement. From a clinical outcomes perspective, we've been able to show how it reduces escalation of care, reduces the mortality rate of patients, improves patient comfort and compliance, and symptomatic relief. It also reduces exacerbation days in your chronic COPD patients. Potential benefits include reducing length of stay, reduced cost of care, and improved patient care and outcomes. So Mandy, that's the main presentation that I prepared. One of the things I think I'd like to just quickly go through is our little ED flyer. I just want to pop it onto full screen mode and just summarize from an emergency department perspective when using F&P Optiflow or EVO2 or nasal high flow therapy. Most importantly, we need to recognize patients who can benefit from nasal high flow therapy. We then want to stabilize these patients to evaluate their condition, and as soon as we can, mobilize patients onwards out of the ED, either to a ward or to a high care or ICU facility. Who can benefit from Optiflow nasal high flow therapy? As Michelle originally mentioned, all spontaneously breathing patients with or at risk of respiratory distress. So who are these? Okay. All right, Mandy, are you not seeing my screen?
Kath, I'm seeing key mechanisms, physiological outcomes, clinical outcomes, potential benefits. That's what's on your screen at the moment.
Okay, let me see if I can get this to where it to be. Let me just reconnect. I'm going to stop share and start again.
Yeah, there you go. Recognize.
Okay. Yeah. All right. Sorry about that. So as I was saying, this is our just a synopsis on specifically using Optiflow and EVO2 in the ED or nasal high flow therapy. It's important to recognize patients who can benefit from nasal high flow therapy, to stabilize these patients and evaluate their condition, and then obviously mobilize them to a ward as soon as possible. Who can benefit from Optiflow nasal high flow therapy? As Michelle mentioned previously, spontaneously breathing patients with or at risk of respiratory distress. So these are the patients with low saturation, high PaCO2, patients with a high work of breathing. It's important to look at your patients and look and assess the work of breathing, patients with a high respiratory rate, and obviously patients who are battling to breathe and who have dyspnea. This is the Optiflow clock, and this is really a nice way of evaluating whether your nasal high flow therapy is working. And you can see that very quickly, once you've optimized nasal high flow, you can evaluate whether the patient is actually responding positively or not. So within 5 to 15 minutes, you'd like to see a decrease in the respiratory rate. Within 15 minutes, an increase in oxygenation. Within 5 to 30 minutes, a decrease in the difficulty of breathing for your patients. And then within 30 minutes, overall decreased work of breathing. Look at that supraclavicular retraction and the thoracoabdominal asynchrony. nasal high flow really does work quite quickly for patients who are going to respond. So you don't need to leave them on excessively. If they are not responding, evaluate them, use the RUX Index, and make a decision whether you need to escalate or not. So Mandy, that concludes the presentation, and I'm happy to discuss questions if there are any. Thank you again for the opportunity to present Evo and Optiflow.
Thanks very much, Kathy and Michelle. Are there any questions? Ultimately, what I'm trying to look at here is I'm trying to move away from every patient in an emergency department getting an endotracheal tube, because it seems like the easiest thing to do, but in the long run, the outcomes are poor. And I think that in every emergency department, there should be a high flow nasal set up, ready to use for that patient with fractured ribs, that patient with respiratory distress, that patient that may have a DNR that doesn't need intubation. And I think that the only reason we don't use it is probably because of lack of understanding and fear. Are there any questions from anybody? You can raise your hand. I don't know if you can mute yourself, unmute. Is there anyone who would like to ask a question? Prof. Kramer, you had a question about nasal high flow and asthma. Would you like to unmute and just ask that?
I just want to know, because we're talking chronic obstructive airway disease was mentioned, and dyspnea was mentioned, and everything else mentioned. I really enjoyed the presentation. It's always nice to learn something new. But the acute asthma wasn't mentioned at all. So I just want to know whether that's been done at all, tried at all, or any hopeful about that, because it fits into everything that you've talked about.
Kathy, from acute asthma?
So I'm off the top of my head, I'm not aware that there's a specific trial. We can ask Chris Greville if he's aware. Chris, if you're online and you are aware, are you able to reply to Prof. Kramer?
Yep, I'm here. I hope you guys can hear me all right. Firstly, thanks very much for having me along. I guess the best answer to that is that asthmatic patients were included in a bunch of the studies that have already been mentioned. What we can do is we can dig those out for you and show you the exact inclusions, just so you can draw your own conclusion from that study. But I'm not aware of any actual studies looking specifically at asthmatic patients.
So
I think it would make a fantastic if you could, because as Mandy said, the one patients that are really difficult to intubate and ventilate is the asthmatic. And if you can get away with 1 out of 10 or 1 out of 20 ventilating difficult asthmatics, you really made something different there. And you might get to the point where they might get to where they don't need it at the end of the day. Because we're using non-invasive, so non-invasive is being used, no reason why high flow nasal should have some role somewhere. And seeing as going to be in the ED anyway.
Yeah, absolutely. And I guess the best paper to point to would be the Bell paper. So that's the one that Kathy mentioned out of Australia in 2015. And that looked at all comers. So that was a comparison of Optiflow versus conventional oxygen therapy in undifferentiated shortness of breath. And so that would have included some asthmatic patients. And it does give a pretty good summary of the types of patients that would come into an ED frequently. Like you're talking about, the numbers of asthmatic patients having exacerbation would be in that group for sure.
Thank you. I'll get that paper, please, Kathy.
Yeah, we'll forward it on to you. It's Bell et al. Of 2015, but we'll forward it on to you.
Thanks very much. Thanks for the presentation. It was great.
Thank you. Thank you.
Are there any other questions from anybody? So just to let you know that this presentation will be on the Netcare YouTube site. I'll ask Chris Matthew to put it up so it can be played to your staff. And Kathy, perhaps the next one we can talk is practical application. What does the machine look like? How do we put it together? How do we troubleshoot it? All that kind of stuff.
Perfect. Absolutely. Thank you, Mandy. Just to mention, I think Chris might just chat briefly about the training platform that Fisher & Paykel will make available to Netcare. Chris, if you could just briefly explain to them how it will work, that would be great.
Yeah, sure. With the advent of COVID, it's made it very clear that it's very difficult for Fisher & Paykel representatives to get into hospitals to train staff on new therapies and products that they might be adopting. And obviously, because this has been adopted very quickly all over the world, we've had to scale up training facilities, which are now digital. So what we've done is basically made a platform where you can choose via sending a list of emails of people that you would like to be included, and we can tailor this educational platform for them. And that includes basically an introduction to the therapy, what the product looks like, how to use it, and then it will spit out a list for you to show you who's done it, which is quite important for those in the management side of things to see who's had the first level of education, and that's been really well received all over the world, really, because everyone's in the same boat, not being able to basically have people come in and do education in person. So that's a facility that we have if there's any interest from your side.
And there definitely is an interest from our side, Chris. And I'm just wondering if the details can be sent to me so that I can send it out to all the staff and that we can get going and they can do some training with their own staff in their own departments.
Absolutely, Mandy, I'm sure, Kathy.
Yeah, we'll get that through to you, Mandy.
Thank you very much.
Yeah, just quickly put on the screen the Optiflow Connect, which I think Chris is speaking about. And this is just to show you, not with the squiggle, I don't know how I did that.
And there's no children around.
Yeah, this is basically what it looks like in terms of the platform. So no problem, Mandy. I'll make sure that you get all of that information, as well as access to the Fisher & Paykel support. I just wanted to show you in terms of, let me just go back here. In terms of the documents that we have, an EVO2 resources guide will be made available to you with tons of information in terms of clinical application, in terms of how it works, mechanisms, in terms of the algorithms. There's a lot of information there, and you guys can access that and look at what you need to specifically.
I think, Mandy, I also want to mention with Wave 3 presumably being around the corner, Fisher & Paykel regularly updates us with the COVID-19 and a nasal high flow dashboard, which is regularly updated according to the WHO regulations and guidelines, the latest studies which are published. So between Kathy and ourselves, we will keep you updated as well in general on these updates so that everybody's up to speed with what's the latest literature relating to COVID-19.
Stunning. Well, while you're still busy on the third wave, I'm on the fourth wave already. So anyway,
yes, Chris?
And Michelle, just one thing to add around asthma, which just came to mind, is that there is a breathing circuit specific to the Airvo where you can tee in a nebulizer where salbutamol can be added. So it is tailorable to asthmatic patients in that respect as well. Sorry, I didn't mention that earlier.
Perfect. Well, it seems like you all enjoyed the talk. As you can see, 22 out of 39, 56 people have voted. All have said they've enjoyed the talk, Kath, and everybody online, Michelle, and I really appreciate you taking such an early morning talk. I don't know what time it is where you are, Graham, probably 3:30 in the morning. Chris, I'm not sure where you are. You're in Australia?
Yeah, close, New Zealand, but yeah, it's about 6 here, 6 p.m.
6. Oh, that's all right. At least we got you at a decent time. Thanks, guys. We'll book something for a few weeks' time again. Appreciate it. Okie dokes.
Thank you very much. Thank you, everyone.
Thank you very much. Appreciate it.
Enjoy your day. Bye-bye.
Bye.